This is the Senate Budget and Taxation Committee Health and Human Services Subcommittee. This is our first budget hearing for 2022. And we are again virtual, though none of us could have predicted this. Here we are again looking at each other on the screen. We're going to have two overviews or two budgets that we're going to hear today. We're really pleased to be joined again by our committee staff, Philip Anthony. And for those in the public, we have 4 senators serving on this committee. Our veteran senator on the committee from the Shore, Senator Addie Eckert. We have the vice chair of the Budget and Tax Committee, Senator Jim Rosapap. We also have from Frederick and Washington counties, the newest member of the subcommittee, Senator Young, with us. And I'm Senator Melanie Griffith. I'm the chair of the subcommittee. We're going to meet our very thorough and hardworking analysts in just a few moments as they do their presentations. We're going to start with the MDH overview, and I have Ms. Wagner presenting. Good afternoon.
Good afternoon. Thank you very much, Madam Chair and members of the committee. I will go ahead and share my screen so that you can see the health overview as I'm walking through it. And I apologize, let me just get that set up. All right, can everyone see my screen? Wonderful. So to start us off, so this is the health overview analysis for the fiscal 23, for the governor's budget plan for fiscal 23. This first chart shows the 5-year funding trends. As you can see, over the past few years, the budget for the health department has grown substantially from about $14 billion to closer to $18 billion most recently. And that's mainly due to one-time federal stimulus and other federal aid to respond to the COVID-19 pandemic. However, in fiscal 23, you are seeing that the budget does decrease slightly by $625 million as a lot of the one-time federal funds end. However, this is partially offset by an increase in general funds, as shown in blue, as general funds are used to backfill some of the federal funds that are falling off in fiscal 23. Next, I'll jump over to the fiscal 22 actions. We wanted to acknowledge the cyber attack that the department has been dealing with since December 4th, but this analysis in particular won't go into detail on how that's been affecting the agency, and that will be discussed in one of the later budget hearings. And just as a general note, this is an overview briefing on the health department's budget, but the respective divisions and offices will also get their own budget hearings. So a lot of these changes in the budget and issues will be discussed in further detail later as the session goes on. In terms of deficiency appropriations, these are appropriations adding or subtracting money from the fiscal 22 budget. There's $56.1 million added related to the pandemic. I will highlight that almost $9 million of that is added for overtime expenses, and that's mainly in the state health facilities. There's also a deficiency adding just under $340 million to cover behavioral health services that were rendered in service year 21, but will be paid in fiscal 22. And so that's the fiscal 22 changes. This next chart shows the Department of Health's budget by function, or how the funds are being spent. I would like to note that more than 85% of the health department's budget supports healthcare in different forms through the Medicaid program, accounting for 66% of the budget. But then there's also spending for behavioral health services and for developmentally disabled people for their services for another 20% of the budget. So then moving on to the change in the budget from fiscal 22 to fiscal 23. This chart shows an itemized list of some of the major changes. I'll just highlight a few of the items. So this first part shows the regular personnel change. Regular personnel increases by about $8 million, but I will note that this exhibit doesn't include things like cost of living adjustments, bonuses, annual salary reviews, and other actions that are actually budgeted centrally under the Department of Budget and Management. But it is important to note that those are also funded in this fiscal 23 budget. They're just not showing up specifically in the Department of Health's programs. In the health regulatory commissions, I'll just highlight two of the larger changes there. There is about $50 million in new funding for the Consortium on Coordinated Community Supports. This is the first year of a blueprint initiative, and this funding will mainly support grants. There's also $15 million for grants for the new health equity resource communities that came out of a bill last year. I'll jump ahead to the Behavioral Health Administration. Here, there is funding to cover 3.25% mandated provider rate increases. The health department, then the next major changes at the health department is accounting for recoupments related to the ASO issue. And then overall, though, BHA is showing about a $400 million decrease in fiscal 22. And that's mainly due to these deficiencies where they're adding in funding for COVID-related federal funds and then those reimbursements for service year 21 spending that they're actually paying in fiscal 22. So if you took out those deficiencies, you would actually see BHA's budget largely level. Other than the rate increases, BHA's budget is generally level funded. In the Prevention and Health Promotion Administration for public health, you're seeing a decrease of about $470 million. This is where you're seeing a lot of those COVID-related federal funds coming off of the budget in fiscal 23. I tried to break out a few of these different funding sources here. This will, of course, be detailed further in the FIPA analysis, but this is where you're seeing a lot of the federal funds coming out of the state budget. And then moving on to Medicaid, again, you're seeing provider rate increases being funded. This is mandated 4% rate increases for Medicaid. For Medicaid providers, there's also, I didn't mention this, but DDA's 4% provider rate increases are also funded in fiscal 23. And then for Medicaid, I will also note that these provider rate increases also include rate increases for dental services and for physician rates. Specifically on physician rates, in prior years, those were funded at about 93% of Medicare rates, but the fiscal 23 budget actually includes funding for about 100% of Medicare rates. And then I'll also highlight under the Medicaid program that there is about $40 million in additional funding for the Population Health Incentive Program. That was formerly the Value-Based Purchasing Program. And then included in that is the Maryland Quality Innovation Program. So that's what this line is showing here. But of course, all these funding changes will be discussed along as session progresses through other budget hearings. So this exhibit talks about federal stimulus received by the health department. Of course, the health department has played an outsized role in the COVID pandemic response. And so you're seeing a lot of the COVID related spending in this budget. One of the ways that the health department has been receiving federal aid is through a 6.2% enhanced match on Medicaid spending. This was authorized in the Family's First Coronavirus Response Act and has been in effect throughout the entire national declaration of a public health emergency. And so this funding will be, this 6.2% enhanced federal match will be in effect through the last quarter that the public health emergency is in effect. So most recently it was scheduled to end January 15th, but it's been extended through April 15th. And so we're now expecting this enhanced match to continue through the end of fiscal 22. And so because of the timing of when the budget was introduced, the budget assumes that this enhanced funding ends in the third quarter of fiscal 22. But of course, now that we know it's most likely extended into that last quarter, there will be additional federal funds coming and additional general fund savings from that. The other thing I'll highlight is that the American Rescue Plan Act included 10% enhanced federal matching specifically on the state's spending on home and community-based services. And there's a requirement that this enhanced federal funding get reinvested back into home and community-based services. And so I'll discuss that a little bit more in the issue section, but that's another source of federal aid. This chart goes through a lot of different kind of buckets of funding that is to respond to the COVID pandemic, but I'll also highlight that there is also the FEMA Public Assistance Grant Program that reimburses the state for a lot of COVID response spending. There was a BRFA action last year that basically allowed the state to use local income tax reserve funding as a placeholder that will later be backfilled with the FEMA reimbursement that the state expects to receive. So that's making up about $800 million in fiscal 22. And then I'll also highlight that the CDC, through existing grants with the CDC, the state is receiving a lot of funding for COVID testing and tracing efforts. They're receiving a little over $500 million for this. And so that's one of the funding sources that is mainly budgeted in fiscal 22. And then you're seeing it fall off in fiscal 23 as a one-time grant. Let's see. The other thing I'll highlight with this exhibit is that, of course, the pandemic has also had an outsized impact on mental health and behavioral health. And so there is federal funding supporting mental health services. There's about $127 million in grants specifically for that purpose. So I did just want to highlight that there. So then I'll move on to a discussion on Medicaid enrollment trends. So going back to that 6.2% enhanced match I was discussing, one of the conditions of states receiving that funding is that Medicaid programs can't disenroll or do eligibility redeterminations while the state is receiving that funding. And so throughout the pandemic, Medicaid has not disenrolled people generally. And this is, and then also because of the economic impact and the health impact of the pandemic, there has been a large increase in Medicaid enrollment. You can see that in the first year of the pandemic, the enrollment monthly growth was, peaked in May 2020 with almost 20,000 people added to the program. But then more recently, over the past few months, the new additions have ranged between 9,000 and 10,000 people or so. So that is driving Medicaid enrollment to rise. And most recently, it was around 1.6 million people on the Medicaid program. And that's almost a quarter of the state. So then the budget assumes that the national public health emergency would have ended in the third quarter. So eligibility redetermination would resume in fiscal 22. And so the budget is based on an assumption that enrollment will decline to about 1.5 million. And that's what the fiscal 23 budget is based on. Again, because of the extension of the public health emergency, redeterminations now won't resume until July 1st. So now moving on to a discussion on personnel, I'll pass it over to Andrew Garrison.
Thanks, Ann. So looking at the overview of the health department's personnel budget, what we did for you on Exhibit 1 here is we took a current snapshot of everyone who's working at MPH in January 1 of this year. And we wanted to see how long they've been in state service. And we broke them up into 3 groups. We have folks who work in kind of administrative or regulatory functions throughout MDH. We have those folks who are working at our state hospitals and state healthcare facilities. And then we also have a chunk of the public health workforce that's actually state employees. There are some limitations as to exactly who falls into that. We thought it was interesting to include them in this discussion. And so on Exhibit 1 here, we're showing that by and large, a lot of the folks who are working at the health department have been with the state for 4 or fewer years. That's about 40%, and that's true across all those different employment groups. And then that next chunk as well is 20%, so still under 10 years. I'm just looking at 5 to 9 there, and also, again, largely true no matter what job that we have. So we have a relatively lower tenured state workforce. The administrative folks on a rate basis are just a little bit higher by a couple percentage points or 2, but that is broadly true. And then obviously we tail off towards the end there. The other thing we wanted to look at in Exhibit 2, particularly given that the public health emergency and the pandemic has obviously put a particular impact on the health department's workforce, what we wanted to look at is take that snapshot that we just had from January 1 of this year, and then go back to January 2020, so before the pandemic. And we took both of those data sets and we matched up positions and the position ID numbers and accounted for transfers or reclassifying of PINs, and wanted to see who was still with the state from that 2020 cohort is still with us now that we're about 18 months into a health crisis. And what we see is that about 10% in both the administrative and then a little bit more than that in the direct care have left state service since 2020. Or at least left the health department rather. But when we look at those public health individuals who are budgeted with the state, we see that a lot higher. It's about 20%, 1 in 5 of the folks who were there in 2020. In that paragraph below Exhibit 2, we do talk about some of the limitations as to who exactly we have on the books there. Certain local health departments, not all of their staff is budgeted here. So it really is just kind of a snapshot of these, but we still thought it was interesting to point out really some of the changes and perhaps the particular stress that's happened on our healthcare workforce in the state, but perhaps that public health workforce in particular. And of course, this is something that we're going to get into later on throughout the session, in particular in the health department's administration analysis. That's where a lot of those hospital workforce are as well. And so we really want to be tackling and looking at the impact of the pandemic has had on those employees in the state. And then lastly, on the personnel front, Exhibit 3 shows department-wide vacancies. And here we're just looking at the administrative group and then that direct care group. And as you can see by those filled pin bars, that's traditionally about a 60-40 split, with a little bit more of the health department workforce being in those direct care, in those facilities, rather than on the administrative side. And so when we do have changes in their vacancy rate, that does tend to drive the overall health department vacancy rate. And although this hasn't always been the case, you see that in the last several months here, the last 6 or 8 months or so, those have kind of switched, where the vacancy rate for our direct care staff in the state has then exceeded the rate of those in the administrative roles. And so those are the folks who are still going into hospitals and healthcare facilities every day. And we are seeing a higher vacancy rate with them currently. But again, this is something that we're going to continue to look at and be really interested in, particularly with some of the salary actions that have happened statewide that Anne has mentioned, and seeing what impact that has had on our health department's workforce. And that is all that I have for you all on the personnel side of things.
Okay, so then that kind of ends the budget discussion on health overview. We do have 2 issues for you today to highlight some of the kind of topics that have been affecting the health department overall. And so we have the first one is on home and community-based service waiver expansion. The health department administers a couple different Medicaid waivers that help pay for people to receive assistance in their homes rather than going to a nursing facility or going to a state health facility. The DDA supports 3 of these waiver programs, and then Medicaid supports the Community Options Waiver, Community First Choice, and a couple other programs. There's also the autism waiver that's actually administered by the Maryland State Department of Education. So I won't get into that one too much, but that is also another home and community-based waiver service provided in the state. So to start with this issue, we wanted to highlight that a few of these waiver programs have experienced waiting lists and registries over the past few years. The first being DDA. And I'll also note Morgan Smith is a DLS analyst who's also on the call for questions about DDA. So she's also here for any questions you all have. But this first exhibit shows that the DDA community service waiting list count has remained above about 3,500 people each year. You are seeing a decline from 2018 to 2020 as DDA brought on 2 new waiver programs. But we just wanted to emphasize that there still is a waiting list count of people who are not currently on the waiver programs and receiving DDA funded home and community-based services. The other program we wanted to highlight is I apologize, jumped too fast. The Community Options Waiver Program administered by Medicaid. And so this program, there was actually in the 2020 Joint Chairman's Report, it was requested that the Hilltop Institute do a cost benefit analysis on expanding this program. And they had a few findings. Part of this analysis, they also looked at the registry for this program. As of September 2020, there were just under 20,000 individuals on the registry for this program. Hilltop found that only about 3,088 or 15.6% of the registry would meet the level of care and the financial eligibility requirements to qualify for a waiver slot if offered. Another finding is that almost half of the registrants on this registry have been on it for 3 years or longer. So you do have long wait times on the registry showing over 3 years. And then the other finding from this analysis is that Medicaid has not been filling all of its authorized slots for this program. What this is showing in the blue bars is the maximum capacity of slots that Medicaid could fill. And then the orange bars are showing unduplicated counts of annual enrollment. And then the line shows the percentage of waiver slot occupancy. So not all slots are filled for the entirety of the year. So the occupancy kind of gets a better sense of how many slots are filled over the year rather than counts of enrollment. And over the past 4 years shown, the waiver slot occupancy has ranged between about 70% and 80%. And so the department has offered a couple reasons for not using its maximum number of approved slots. This includes keeping keeping open slots so that there doesn't have to be a waiver application to the Centers for Medicare and Medicaid Services every time someone's added to the waiver. They've also indicated there's a limited capacity of the provider network that serves both the entitlement Medicaid population and the waiver population. And then the third reason is that the methods for pulling people off of the waiver registry there have been recent efforts to change how that is going, whether it's moving from a first come first serve methodology to one that prioritizes people based on need. These are different efforts that the department has described as trying to kind of change the methodology for taking people off of the registry. But kind of shifting here, there have been recent efforts to expand funding and the number of slots in home and community-based services. So I've highlighted a few here with this list. So in fiscal 22, one of the supplemental budgets added $10.6 million for 400 additional new slots and 6 regular positions under the community options waiver to expand. And also the regular positions are meant to improve the personnel capacity to get people off of the registry. And then there was also $2 million added for 100 additional slots under the autism waiver and $1.8 million to establish new PACE sites. That's another program providing home and community-based services. In fiscal 23, I'll highlight that the DDA budget has $30.2 million for new placements and services for expansion under its waiver programs. There is $12.6 million for 400 new slots under community options on top of those 400 slots authorized in fiscal 22. And then there's $2.8 million to fill 100 slots under the autism waiver. And then kind of returning to the discussion of enhanced federal funding, as I described, the American Rescue Plan Act authorized 10% enhanced funding for home and community-based service spending particularly. And so this funding must be reinvested into the services and can be reinvested through fiscal 2024. So there was budget language last year that specified 75% of this funding must be used to support rate increases for home and community-based service providers. And so this list here shows that 5.5% will be the rate increase for DDA providers, 5.4% is authorized for behavioral health providers, and then 5.2% is approved for Medicaid providers of home and community-based services. And so this, for Medicaid and behavioral health, this was added to the budget through a deficiency for fiscal 22, but there was not a deficiency for DDA. So we just asked the department to provide its latest estimate for how much matching funds they will claim under DDA, and then explain whether this funding is reflected in the budget or not. And then also in that budget language from last year for DDA specifically, the enhanced match is also, it specified that the other 25% must be used on grants to DDA providers, with up to 5% being able to be used on administrative costs. And so DDA and MDH has specified how they might use these DDA grants, or the providers might use these grants, but we also asked the department to comment on its timeline for reinvesting the enhanced federal matching as a whole across Medicaid and BHA, and then explain how, since the Medicaid and BHA budget language didn't specify the remaining amounts of funding, to explain how MDH is planning on using that remaining funding. So that's it on the first issue on home and community-based services. I'll now walk through the second issue. We wanted to highlight different efforts that Maryland is undertaking, specifically on maternal mortality rates. And recently, so this exhibit shows recent maternal mortality rates across Maryland and then also by race. You can see that there's still a large disparity between non-Hispanic Black people in Maryland and then non-Hispanic white people in Maryland in maternal mortality rates. Most recently, white women had their maternal mortality rate had declined lower than the CDC Healthy People target, while the statewide maternal mortality rate and then the rate among non-Hispanic Black women still is pretty significantly higher than that goal. And this disparity is actually worsening. In 2013, the 5-year average gap was more around 2. Non-Hispanic Black women had about 2 times higher maternal mortality rates, but more recently it's grown to almost 4 times. So not only is the maternal mortality rate, even though on a statewide basis it's improved lately, the disparity has actually worsened. And so we wanted to highlight that there has been state legislation to address this issue and improve maternal mortality rates in general. This includes certifying or reimbursing for certified midwives. This includes expanding postpartum Medicaid eligibility. Currently, Medicaid covers 60 days postpartum for women, for pregnant women. However, a new bill would require that Medicaid cover a full year at postpartum. So that is one expansion that will be going into effect soon once Medicaid applies for a state plan amendment implementing this change. And then there's also new funding through the Prenatal and Infant Care Grant Program Fund. It's required that this is funded at $1.1 million in fiscal 23. I'll highlight that the fiscal 23 allowance budgeted only $1 million for this fund, but this is a $900,000 addition compared to fiscal 23. The other place I'll highlight that there's additional funding for maternal and child health is that that Maryland has chosen maternal and child health as one of its population health goals as part of the total cost of care model and its statewide integrated health improvement strategy. So through this, the HSCRC has actually reserved funding to provide grants for maternal and child health related programs. I've outlined these here, so I won't go through too much about what these programs all do, but this includes home visiting, it includes coverage of doula services, and it also includes programs that are specifically meant to deal with opioid use disorder that is affecting pregnant women. So these are all new programs that would be funded with this additional funding. I think it's about $72 million that is being used on these programs. So that is it for that issue. There's one update on the cigarette restitution fund, but due to time, I won't go through that in detail. But other than that, that concludes our presentation, and I'm happy to answer any questions you all have.
Thank you very much. Colleagues, are there any questions for the analysts? I don't see any hands raised. If you have a question, colleagues, just use your raise hand feature or just raise your hand and I'll make sure you get acknowledged. Okay, I don't see any questions for the analyst. And I think, first of all, thank you. This was very thorough overview. I know that we'll do a deeper dive into some of these issues when we do the administration budget briefings. So we'll look forward to seeing you all back again, maybe even tomorrow, who knows? Thank you so much. We're going to turn it over to the Secretary of the Maryland Department of Health. Good afternoon, Mr. Secretary. Really appreciate your being here. We know that there's been so much going on in the Maryland Department of Health from the last time we were all here together. We know you and your team have been working tirelessly on behalf of the state. I'll look forward to, as will my colleagues, your response to the analyst presentation and anything else you'd like to share with the committee. And you should feel free to introduce anyone that has joined you today. We'll turn the Zoom room over to you. Thanks so much.
Thank you, Madam President Pro Tem and members of the committee. I want to thank you for having us today. I find this to be very important work, and despite all the other things going on, I think it's critical that I be involved and plan to be as many of these as possible over the next 45 days, because I believe this to be essential. I'm joined today by our new CFO, Emily Brandenburg, who's sitting to my right. We have hired her, and she's come over from the Maryland State Department of Education, and we're delighted to have her. She also has significant experience at the local level with Anne Arundel County government. So we welcome her, and you'll be hearing from her in a minute. Also, we have Nick Napolitano, our budget director, and Webster Yee, our assistant secretary, who will offer some responses to the DLS analyst questions. I also want to thank Ann Wagner and the other analysts. I always get a lot out of these reports and feel they're very, very well done and insightful. And so thank you for that. I'm going to ask Webster Yee to address the two analyst questions, and then we'll be prepared to take questions from the committee. Webster?
Thank you, Mr. Secretary. Madam Speaker, President Pro Tem, members of the committee, Webster Yee, Assistant Secretary at the Maryland Department of Health. We've provided a one-page written document, so I'm not going to read through it in detail. To the first issue regarding the ARPA funding and the 10% FMAP, our spend plan is publicly accessible. In our testimony, there's a link to it, and we would encourage you to go through it in detail, and we're happy to answer questions. I should note that our next version of the spend plan is due to the U.S. Centers for Medicare and Medicaid Services on February 1st, and so we're in the middle of compiling that and getting it out the door. So by the time the DDA and Medicaid budgets roll around, I suspect that the analysts will have new material to work from. Broadly speaking, with the ARPA reinvestments, we have spent an extraordinary amount of time working with especially the DD Coalition and also the behavioral health and other providers to make sure that we are able to take this one-time opportunity really to level set, conduct rate setting, and get things in a very comfortable position for the next couple of fiscal years so that our providers are on a solid footing for at least the next couple of years. Specifically, our estimates project currently, based on the latest numbers, that we will have about $295 million to reinvest back into the program. Providers received a 5.5% rate increase that was announced on November 1st, and it was retroactive to April 1st, 2021. That rate increase amount is currently projected to be about $221 million. As we go through and get federal approval for all of the other actions that we hope to take, some of that has resulted, for example, in CMS approving us for $50 million in non-competitive grants, $10 million in competitive grants, especially on the DDA side. And we are really taking this as an opportunity to work with the DD provider community to move folks to the long-awaited fee-for-service LTSS Maryland system and off of the older prospective payment system. Moving on a little bit, we're currently working with stakeholders on the details of the $10 million in competitive grants. And with respect to the deficiency appropriation, that was rolled into the budget amendment. There's a signed budget amendment in place, BDM 045-22, which includes $85 million in federal funds for the enhanced FMAP in the DDA budget. To issue number 2, again, we're taking this as a great opportunity to really take a long, hard look at how we can ensure that rates have a very stabilized glide path over the next couple of years. And so, again, in our written response, we put in exactly what we've done. We've, for Medicaid, long-term care services and supports, it's a 5.2% increase. And with behavioral health, it's a 5.4% increase. We've actively solicited stakeholders and their input on how to spend the remaining 25%. Once again, we're going to true up finalize our submission to CMS, get it in before the February 1st deadline, and we'll have more information to report at that point. So with that, we're happy to take questions.
Okay, thank you very much. Are there any questions from the committee? Senator Eckert.
Thank you very much. First, I want to compliment the department and all the good work in their responsiveness. And I guess I have a question. I don't know whether it's appropriate to this or not, but does this budget cover the vaccine reporting? And like once you get tested and then you get a report back, whether you're positive or negative, does this report cover that?
You want me to take that one?
That would be great.
Yeah, so Senator Eckert, embedded in all of these federal dollars are the contracts and services that we have brought in to provide those services. So it's not noted in a detail level, but they're definitely, so for example, contact tracing is noted in here, but we also have enhanced levels in our Immunet, and our CRISP expenditures that pull together all of the reports. But the primary question that you asked is about how does the information flow when you're positive to contact tracing and then the calls. All of that is accounted for in this budget. Yes, ma'am.
And is it only in English? And that's one question, because I'm getting some local reports or some issues with it, and that's why I'm bringing it up at this time. And one is it only in English, and then the second issue is, has the cyber attack impacted the operations of that system so that names would get mixed up?
So on the first, my understanding, and we'll double check this, get back to you, is that we're in English and Spanish. So both English and Spanish. As far as the system, the NORC data they had their own operating system. We have had issues that we've corrected from the information coming out of NEDS, and CRISP. The CRISP folks have helped us pull that together. So we've restored any issues with NORC and the contact tracing data a while ago. That was at the top priority of our restorations, and that's working now. We don't believe there's any problems with that data, but if you hear of complaints, we'd be glad to check into them.
Yeah, I will. And then my next question is it health department specific? I would think you have a centralized system whereby that I receive my results. So, if I get a text that says, go to this website to see whether you're positive or negative, then that's pretty clear, but that's centralized. It's not health department specific, correct?
Senator, if I could answer that, it depends on what type of test you're getting in and what type of lab you're getting it from. So if you get a PCR test in Maryland, every lab that is licensed by the state for PCR testing is required to report immediately to the state's database. So we'll have results. If you're positive, that result is then transmitted to our contact tracing system for follow-up. Obviously, across the nation, there's been this massive surge in PCR testing. So labs that are not directly reporting to the Maryland system may be experiencing delays. With point-of-care tests, which are the rapid 15-minute or less tests, it's up to the citizen or to the lab that's administering the test to report the results. And so that's a little bit more hit or miss. Many citizens, if they take a test at home, might choose not to report the result.
Yeah,
we have established a portal.
That's correct, sir.
Okay. Yeah, I was just getting some reports of some issues with just the reporting of the positives or the negatives, or just, we've had a lot of people test positive, and so they're all grounded for a while, and they're all very anxious to go get that next test, or if they're grounded because they've had an exposure, then they are, and they go and get a test, then they're anxious to get that report back. And that goes for all of our populations, whether it's, our English speaking folks, Spanish speaking folks, or our Haitian folks. And I know I've been just recently, I guess in the past week, given a couple of examples where like the last name became first name, or the first name became the last, and that kind of, it's just curious. We've had a cluster of those kinds of situations recently, and I hadn't heard of that before. So your clarification of depending on the test, I think it was primarily folks who had worked through in our rural area. We pretty much all go through the health department. So just something to check on. And thank you, Madam Chair. Sorry to get into that, but folks are anxious to get their results back.
No problem, Senator. We're here to serve. Any other questions from the committee? Yeah, I just had a couple, not necessarily questions, but comments just to give you, Mr. Secretary and your team. First of all, let me say a lot of the questions that you're going to hear from the committee probably throughout session are going to be COVID primary questions like the senators, but we also recognize that you and the department have been working on the other issues that we and the analysts bring up throughout the year that have been happening long before any of us knew there was a COVID, and will be here before us even once we get through the worst of this pandemic. So I wanted to just mention a couple of things the analysts lifted up, and I wanted to just draw attention to the issue on maternal and child health that I know you all share with us as a priority. As you know, last year, the President's Work Group on Equity and Inclusion held this up as a priority, as a number of entities, and have it as a state priority. So while all of these sort of multi-pronged approach to addressing this issue in our state is evolving, certainly just wanted to let you know that we want to work with you and to continue to track this issue and the results of some of the efforts that we've all worked on together. So we'll probably be asking that we track the data, continue to track the data as we, as these initiatives that we put into place evolve. And then I certainly know that through some other briefings, we'll talk a little bit again about the reimbursements for our providers. That has come up a couple of times, and you've been working with us and the chair during the interim on those issues. And then for all of our agencies, the subcommittee is going to be looking for, as we move through the rest of the budget process, your input on what we all do to address the personnel crisis that we're facing, the workforce crisis. And so I just, Mr. Secretary, I don't know if you want to respond now, but wanted to at least put those things out there so you know where we're headed in the weeks to come.
Everything you said I was expecting to hear about, and the analyst report was very clear. So we've been preparing for detailed questions. And as you said, much of this permeates through everything we're doing. But obviously the maternal health issues and child health, we've elevated to priority status within our 3 population health goals. Of course, we have diabetes as 1, opioid mortality is 2, maternal and child health is 3. We've also, as you know, organized under the leadership of Steve Hsu, the Equity Commission that also is focusing on, and we're integrating the population health issues into a subset of the health equity so that we get some consistency. We want to make sure that the priorities are consistent throughout. So that's definitely something that we want. We're anxious to move along. And of course, the personnel issues, as you mentioned. I would like to point out that in the budget, particularly with the local health departments, we recognize that that's been a problem. We have been, as you know, in the Great Recession, that hit the local health departments very hard. And under Secretary Neal's leadership and my leadership, we have made that a high priority. We have recommended, and the governor's followed up with systematic increases over the last several years. But this year is a historic increase, $23 million plus $9 million in deficiency spending. So we recognize that, and very large part of our workforce is in the local health department. So I'm anxious when Dr. Chan is here with us as we get into the public health area to really explore that. We've also seen some improvements, but not far enough, in our hospital systems with the bill that the legislature passed that allowed us to go to 312s for nurses, 3 12-hour shifts, which is a very popular initiative in the private sector. We brought it into the public sector, and we're seeing some impact there of a positive nature. I will say that currently our difficulties within the hospitals are because of COVID, and that's affecting all the workforce because the workforce is getting ill also when they're out. So that's been putting pressure. But anyway, those are just a handful of things. There's a lot of other issues we'll want to talk about in terms of workforce.
Thank you for that, and we will continue the conversations. We've been talking, I'm sure you know, with Webster and other members of your team about the loan assistance repayment program. I have another bill coming in this session, and also Senate Bill 563 that passed last session, which was ramping up the funding, the core funding for local health departments. So pleased to see what happened this year, but we still have a lot of work to do in terms of truing up our local health department funding. So thank you for that as well. Any other questions, comments from the committee for the Department of Health? Senator Young.
Yeah, I'm still pretty new at this, the health issues. I've been everywhere but this, but assuming this pandemic starts to phase out at some point, which I hope I'm not just being hopeful and it happens, are you looking at any long-term plans? Because I think mental health issues are going to end up taking over as we get out of this. In terms of suicides and a lot of problems that children are having been locked out of school, so to speak, and whatever. Are you looking at any long-term things of phasing in a different direction and ramping up there as we hopefully ramp down on issues like COVID?
So let me answer the second part of your question, and then I'll deal with the first part. We are seeing from SAMHSA, which is the HHS organization, the Substance Abuse and Mental Health organization that funds a lot of a recognition of these issues that have been brought on by COVID, and they're giving us additional funds, as we heard in the analyst report. But if I could come back to the first part of your question, I have a feeling that it's going to be a while before COVID is behind us. The real question is how many more surges will we see? I fully expect we're going to see more. And then what kind of variants are going to pop up? We saw a major shift even in the last few months here with Omicron, which drove quite a bit of this recent surge. This current surge, I expect, will be behind us probably around late February, early March. But then we've got to get ready for the next surge, which could come, we see it over the holiday periods, so it's very likely that in Memorial Day, July 4th cycle, we'll see an uptick, and then during the holiday period again next year. So we are continuing to figure out how do we address a steady state, understanding though that I don't expect that COVID will be ever ending. It's just like the flu season. The analog, if you think about flu, we have about a 40 to 50% uptake in flu vaccine every year, which is nowhere near enough. But except for last year, because of the social distancing and masking that was going on, we had a very low flu season. But it is not unusual in the state of Maryland to see anywhere from 800 to 1,000 flu deaths. I don't find that acceptable either, quite frankly, but we may at some point reach a steady state for COVID, but I don't see that coming very soon. So I think what we've got to do is how are we going to live with COVID in the coming years? And behavioral health is definitely a part of that. I would also say that due to the work of Dr. Jones, we have been doing yeoman's work vaccinating the behavioral health population. We're pushing people to get tested, as you can see, and we're still pushing people to get vaccinated. And the latest thing is getting folks booster shots. I know you're on the Vaccine Oversight Work Group, Senator, but we're about 40 to 50% of the way there with the first boost, and we're expecting that people will have to regularly be updating their shots. So this is going to be a long haul.
Unfortunately, I think you're right about additional surges, but hopefully they're going to become milder and get into the category of flu. I just think we have to keep our eye on the mental health issues as this
Yes.
shift, because I think they're rather large. Thank you.
No question.
Thank you, Senator.
All right, Senator Rosapap, Vice Chair of the committee.
Thank you very much, Madam Chair. I just want to make a comment. I just really appreciated what the Secretary just said. I think we all know, there's been a lot of confusion over the last 2 years about when is COVID going to end. And I think everyone following this is coming to exactly the conclusion that the Secretary did. And I just applaud him for saying it clearly and directly. And it's hard for people to hear. I mean, people want COVID to be over, and it ain't going to be over. It hopefully will not be as bad, but that may or may not be true. And so the notion that we may have significant additional surges is realistic. The fact that we're going to have to manage this over definitely the rest of our lifetimes, but even beyond our lifetimes, is why public health is so important. And I just appreciate the Secretary's very clear statement of that. And I think it would do us all good to share that widely. So thank you, Madam Chair.
Thank you, Senator.
Mr. Secretary, any closing remarks as we conclude the hearing?
No, Madam President Pro Tem, thank you for the opportunity. We're going to be talking quite a bit, I believe, over the next 45 days, and just appreciate the opportunity to have the dialogue. So thank you, and look forward to the next steps.
Very good. Well, thank you to you and your team and to the analysts. That concludes the hearing on the MDH overview. Committee will now turn to the DHS overview, and we have Grace Patterson as our analyst starting out. Good afternoon.
Afternoon, Madam Chair. Thank you. I will share my screen. I'm also joined by the other Human Services budget analysts, Tanya Zimmerman and Samuel Quist. They're available to answer any questions as well. It's my pleasure to present the Department of Human Services Fiscal 2023 budget overview. Looking at the budget changes from the working appropriation to the allowance, the budget decreases almost 40%, and this is mostly driven by federal SNAP benefits that decrease, as well as PEBT benefits that are expected to conclude at the end of fiscal 2022. Most of the budget, the department's budget goes to public assistance payments. The next largest spending category is personnel. Looking at the all funds change, this is broken out, showing the variation in individual administration budgets, all of which decrease except for the Social Services Administration. And the increase there is mostly driven by foster care maintenance payments, and the Child Support Administration increases slightly. Looking at the general fund change, again, social services increases primarily due to provider rate increases there, and OHEP receives $80,000 increase in general funds. All the other administrations decrease from fiscal 2022. The department receives over $3 billion in deficiencies, most of which is for SNAP and PEBT benefits, making up $2.9 million of the addition of the fiscal 2022 working appropriation. Looking at the specific reasons for each budget fluctuation, the biggest changes are in assistance payments, as I mentioned earlier, $1.3 billion of which is for SNAP, $818 million is for PEBT, and some other substantial changes are from the availability of federal funding from the American Rescue Plan Act, and an anticipated decline in temporary cash assistance caseload. The foster care maintenance payments increase overall $22.2 million, mostly due to provider rate increases. It's partially offset by a small caseload decrease. The Office of Home Energy Programs sees a little bit of a give and take. The CEF revenue is expected to increase the budget there by over $50 million, but limited time assistance for water assistance and energy assistance decrease the budget over $80 million there. Another substantial change is results from the conclusion of the MD Think Major IT project. Looking at caseloads, the biggest changes there are for TCA, the TCA CLIF initiative, transitional benefit, TDAP and SNAP, and foster care as well. Looking at the department staffing, 20 long-term vacant positions are abolished. This is only a small portion of the positions that have been vacant for over a year within the department. The department currently has over 250 long-term vacant positions, and their staffing will be further discussed in the DHS administration analysis that you'll hear in a couple weeks. Looking at the percent of positions filled, slightly less positions are filled than were filled this time last year, with about 85% of all positions filled as of January 1st. DLS has a couple issues to discuss, the first of which is temporary cash assistance receipt before and during the pandemic. As you can see in this first exhibit here, since the pandemic began in April, the caseload has remained elevated from pre-pandemic levels, indicating that pre-pandemic levels of economic stability have not been restored for thousands of Maryland families. Looking at the geographic distribution of where those caseload increases are occurring, 6 counties saw more than 500 cases added in the early pandemic months from April to June 2020. And while other counties saw smaller numeric increases, a substantial portion of counties saw growth in their caseloads over 60%. The composition of the TCA caseload also changed substantially before the pandemic. In fiscal 2020, about a third of cases were child only, but in the early pandemic months, this shifted and more than 90% of cases had an adult recipient, kind of driving home those economic stability challenges that families experienced during the pandemic months. Looking at another way to look at this is their employment and earnings in the quarter after receipt with before and after receipt, with individuals coming onto the program during the pandemic, a little more likely to be employed and to have higher earnings. And then cases that were exiting during the pandemic's months were also more likely to have higher earnings than cases exiting before the pandemic. So indicating that those cases that were added during the pandemic months had previously experienced relatively more economic stability, but the pandemic really caused a disruption for those families. Another way to look at the pandemic's effect on human services is to look at the child welfare impacts. So as has been widely reported, child maltreatment reporting is decreased from pre-pandemic rates. And this isn't necessarily reflective of decreased incidence of child maltreatment reporting. And in fact, some states have anecdotally reported that maltreatment cases have been more severe because the cases went longer undetected before they were addressed. So typically the data through December would be available this time of year, but the most recently available data is August. So whether there was an increase in maltreatment reporting as children were able to return to more fully in-person schooling is unclear at this time. So DLS is asking the department to comment on when they think that data might be available. Another way to look at child welfare during the pandemic is this substantial investment in public assistance programs at this time. There's been a lot of federal funding available to support public benefits. And this is interesting in light of a journal article that was published of an article published in the journal Pediatrics, which looked at state spending on public assistance programs from federal fiscal 2010 to 2017. So it's before the pandemic, but it looked at, independent of population risk or federal funding available, each $1,000 spent per person living in poverty by these states was associated with a 4% reduction in maltreatment reports and a 7.7% reduction in child fatalities. So the impact of this extraordinary level of funding for public assistance programs could be really interesting to see whether it does affect maltreatment reporting in the state since the pandemic has began. So DLS recommends that, and also another point of this is that a lot of neglect could be economic stability factors, such as families' inability to afford necessities like diapers or access to childcare. So with this additional funding that's available to those families, that's another component of why it might be interesting to look at the neglect data during this time. So DLS is recommending that DHS submit information about the number of neglect reports by type, and so we could see whether they are due to economic stability factors. That recommendation will be included in the Social Services Administration analysis. Tanya Zimmerman is going to discuss the temporary assistance for needy families funding.
Thank you. So annually, the Maryland receives about $228 million of temporary assistance for needy families, or TANF funding, through the regular block grant. That's the level we received since fiscal 2017. Before that period, it was slightly higher, but effectively at that same level. In addition, since the Great Recession, Maryland has received contingency funds, which are available to states meeting certain criteria. One of those criteria is related to the SNAP participation. In particular, the SNAP caseload being like 10% higher than it in a 3-month period than it was in a 3-month period, a comparable 3-month period in 1994 or 1995. And so Maryland continues to qualify under that criteria and will for the foreseeable future because of the overall SNAP caseload changes during that time. The amount of contingency funds has varied kind of throughout the period of receipt, but has been relatively stable in recent years. And you can see in Exhibit 7 here, Maryland's received $27.2 million in each of the last 2 years, and that's the amount that's expected to be received through fiscal 2023. In addition, the American Rescue Plan Act included one-time funding from the called the Pandemic Emergency Assistance Fund through TANF. It's about $17.8 million that's available for non-recurrent short-term benefits. So we've received a little higher funding in recent during the pandemic as a result of that. The fiscal 2022 budget, as it was submitted, including a fiscal 2021 deficiency appropriation, was expected to fully exhaust the TANF balance. However, subsequent to that, when the American Rescue Plan Act was passed, significant additional funding was made available to states through the State Fiscal Recovery Fund, and substantial changes were made to the state's spending plan for temporary cash assistance. In particular, supplemental budget number 5 to the fiscal 2022 budget included a deficiency appropriation that replaced $100 million of TANF funds with the state fiscal recovery funds, and for fiscal 2022 replaced $40 million of TANF with fiscal recovery funds. Those funds are available to could assist the state in dealing with the higher than expected caseloads. Subsequent to the enactment of the budget, the guidance related to the state fiscal recovery funds indicated that those funds couldn't be used for things spent prior to March 3rd. So as a result, the department could not use all $100 million of the state fiscal recovery funds that were available to it in fiscal 2021. So as a result, the Department of Budget and Management indicated that they planned to use the $50 million that couldn't be used in fiscal 2021 instead in fiscal 2022, and a proposed deficiency appropriation effectuates that change. So as a result, they used $50 million to reduce the need in fiscal 2021, and that resulted in the state having a balance of just under $36 million in TANF in fiscal 2021. Because of the higher level of the state fiscal recovery funds available in fiscal 2022, the anticipated ending balance of TANF is over $125 million, which would be the highest level in any time since at least fiscal 2005. In fiscal 2023, those fund swaps are not anticipated, and so the TANF spending returns to kind of more typical levels. And as a result, the balance slightly decreases, but still remains over $100 million, which will allow the department to retain flexibility over the spending of funds to either increase program spending or save those funds for future years in which general funds are more limited than they currently are. If you turn to Exhibit 8, so this presents information on the TANF spending among various activities over time. Due to the sudden rapid increase in the caseload at the end of fiscal 2020 at the start of the pandemic, the state spent $120 million of TANF on cash assistance and overall spent the highest level of TANF that it had since fiscal 2011. With the availability of the state fiscal recovery funds in fiscal 2021, the spending on cash assistance decreased by over $30 million, even with the higher caseloads. In fiscal 2022, because of the even larger fund swap, the cash assistance spending decreases from TANF to the lowest levels in recent history of $34 million, but those are replaced with the state fiscal recovery funds, and there's in general funds to fully support the program. That $34 million also includes the spending of the TANF Pandemic Emergency Assistance Funds, which are expected to be used to provide kind of a step down of the additional benefit that's been received over the last year. In fiscal 2023, you can see the TANF spending on cash assistance returns to more typical levels. One other item of note here is in fiscal 2021, the spending of TANF continued its recent trends of increased spending on foster care maintenance payments and child welfare services, which partially offsets the decreased spending on cash assistance. And that level remains high in fiscal 2023. If you turn to Exhibit 9, breaks down the spending of TANF in the budget. So 43% of the spending is for cash assistance, and this includes both TCA, along with some of the other supplementary programs, including emergency and diversionary assistance and the transitional benefit for those leaving TCA for employment or income. The second largest area of spending is for foster care maintenance payments, and the level of funding of nearly $35 million budgeted for foster care maintenance payments is the highest since fiscal 2002. If you turn to Exhibit 10, this shows the share of cash assistant TANF spending that's for cash assistance and over time. And it had been relatively level between fiscal 2015 and 2020, even with the high level of spending in fiscal 2020 with the onset of the pandemic. In 2021 and 2022, it dips down because of the fund swaps mentioned previously, but it does return to a more typical level in fiscal 2023. And the last exhibit I have for you, Exhibit 11, presents information on the maintenance of effort spending of the department, or across the state, rather. The overall maintenance of effort in the state, the spending increases by over $100 million in fiscal 2021. And there's two factors really that are driving that. The cash assistance due to the higher caseload accounts for about $60 million of that increase. In addition, the changes that were made to the refundable earned income tax credit during the 2021 session had the effect of increasing the maintenance of effort spending in 2021. And that will continue for the next several years as that legislation extends for a couple of years. And so the state did exceed the required maintenance of effort by well over 100 million in fiscal 2021, and it was expected to continue at that high level through fiscal 2023. And I'll turn it back over to Grace for the final issue.
Thanks, Tanya. The last issue DLS has is on the relocation of DHS's headquarters to downtown Baltimore City. This is an initiative, an administration initiative for state agencies to be relocated from the State Center complex to the downtown Central Business District. So DHS, as you can see in Exhibit 12, is their current location is already within the relocation boundary, so it's not clear how much revitalization potential there is. A stated goal of the move was to revitalize the Central Business District, but already being located there, it's unclear how much new revitalization could be added, but more than 70% of DHS's workforce could either telework or work on a hybrid basis. So there could be other benefits to the relocation. So DLS is asking the department to comment on the hoped for outcomes of this relocation and when it expects to effectuate the move. So that concludes my presentation. I'd be happy to take any questions. Thank you.
Thank you very much for that presentation. We'll turn to Senator Eckert.
Thank you very much, Madam Chair. And thank you for that wonderful report. I appreciate that. But I had a question about the maintenance of effort. when we were talking about the earned income tax credit and did that then leverage additional funds? And when we look at that chart, it says what's needed for the maintenance of effort, but then there was somewhat 100 million. I don't have the chart in front of me, but 100 million in excess. Now, where does that money go? Is that in excess of, so is it like it's excess revenue over expenses, and then is that available to be turned back into the program? And maybe I read that and I was just paying attention to something else.
The excess just shows that they're well positioned to continue to meet the required levels. So to receive the TANF block grant, you have to have certain levels of spending, and that's based on kind of the spending on the predecessor programs. And then with the receipt of the contingency funds, there's kind of additional requirements related to that to ensure that the state is also putting forth funds for these populations. So it's just showing the state continues to be in a good position to meet those required levels, and they have done so in recent years. It's
okay. So is it, let's look at the required maintenance of effort. So that base and contingency are state funds?
Those are the amounts that are required the state has to have spending that equals those levels. The state can certainly have more money. This is just showing, that just shows what the state is required to spend to continue receiving the federal funding. And so the excess just shows that the state continues to be well positioned to meet those required levels.
So let me ask you this: if we, okay, now let me go back up. So the maintenance of effort that's required by the feds offsets the $380 million expenditures?
It does not. So that this is just showing the state spent $376 million that could be counted towards the maintenance of effort. The state was required to spend $240 million. So it's just showing the state spent more than was required.
Okay. So that means that there's an extra 140 million or 1,000 that can be turned into next year's budget?
No, this is just, it's an annual requirement that the state has to spend a certain level of funding to continue to receive the block grant and these contingency funds. And that just shows the state well exceeded the amount that they were required to spend. It's not funding that can be transferred from year to year. You have to meet the requirement every year.
Right, but okay, I guess I didn't understand. If you have 143,000.
So Senator, I think what the Ms. Zimmerman is explaining, if I understand it correctly, is that there's a required amount, this 212,906
Right.
that we must spend in order to get the federal money. The column, the section above that is reflecting that we spent more than the 212, and it's showing how much more and breaks down what we spent it on.
Got it.
The
All right.
excess number is just what we spent above the 212,907.
All right, thank you. I'm sorry.
Correct, Ms. Zimmerman?
Yes, there is an earlier chart that provides information on the balance of the TANF funds that are the funds that carry over from year to year. And that is Exhibit 7. So there are funds that are being carried forward, but it is not the maintenance of effort funding.
Got it. Thank you. That's much clearer. I tell you, TCA and TANF have a whole different meaning when you have a lot of people who don't have any resources. So that's why I'm a little more attuned to this. So thank you.
Oh, good questions. It's a lot of acronyms and a lot of money for us to try to track and understand. So,
Right.
any other questions for the analyst? Senator Young?
Yes, thank you, Madam Chair. I have a question in terms of comment about relocating. What kind of feedback have you gotten from your clients? I certainly like the idea of some working from home for a lot of circumstances, but to be very honest, I have in the last year and a half not made one call to state government that I got who I was calling. I got a message or working from home and somebody would get back to me, or message to direct me to a web page or whatever. And I have some concerns about that. Or what kind of feedback are you getting it from people you deal with when they're trying to reach someone for assistance?
Thank you for that question, Senator Young. Is that for the department, or I haven't heard anything specifically to that point, but I'm sure DHS could expand on it.
Oh, well, I was just referring, you were saying that you wouldn't necessarily need to move, or 60-70% of your work could be done off-site. And so I'm just wondering what kind of comments you're getting. Are people reaching you when you're working off-site? You know, when I've made calls, and sometimes it's referred me to a home number or whatever, and I call and I never get a response. I get a message. And so
Senator Young, I think that's a really good question for the secretary and her team.
Okay.
If there are no questions, no additional questions for the analyst, then we can turn it over to the secretary and can start with your question and then go through the response.
Okay, thanks.
Okay, Madam Secretary, good afternoon. It's good to see you again, and certainly appreciate your team being here with you. If you want to let us know who's with you, and we'd love to hear your response to the analysis and also to Senator Young's question. So we'll turn over the Zoom to you.
Thank you, Chairman Griffin, Vice Chair, and members of the committee for the opportunity to discuss the FY 2023 budget allowance for the DHS overview. I have my team here today with me: Gregory James, Deputy Secretary for Operations; Ms. Anna Brett in the back, Deputy Secretary for Programs; Denise Conway, Deputy Executive Director, Social Service Administration; Dr. Chipango, Chief Financial Officer, and other members of our leadership team are also with me. I want to take the time to thank Tanya Zimmerman, Grace Pedersen, and Samuel Twist for the comprehensive and concise analysis for DHS budget. They're a pleasure to work with, and we appreciate all of their support. You have my written testimony, which I won't repeat here. And before I address the 4 issues in the analysis, which Senator Young addresses one of the issues, I would like to take time to share some of our accomplishments, and I will be brief. In the Family Investment Administration, Maryland families continue to face significant challenges during the second year of the COVID-19 pandemic, and DHS has been there to help. Our mission has never been more important. And let me take this opportunity to thank the dedicated, hardworking staff of DHS and our 24 local departments of social services. They have gone above and beyond to ensure that Marylanders receive assistance and benefits to weather this pandemic, and continue to do so today. The Family Investment Administration now manages over 770,000 cases across all the programs. FIA safety net programs are serving 300,000 cases more individual recipients compared to pre-pandemic caseload levels. This represents a 35% increase in the number of cases served. The pandemic EBT program, administered by FIA in coordination with the Maryland State Department of Education, is providing $1 billion in benefits to more than 550,000 children who were eligible for free or reduced price school meals, but unable to access those meals due to COVID-19 remote learning. We continue to distribute the emergency allotment benefit as part of the SNAP program, resulting in over $1 billion in additional benefits provided to active SNAP recipients. TDAP recipients saw monthly benefits increase from $243 to $256 on July 1st, 2021, and receive another increase to $328 on January 1st, 2022. This increase now aligns the TDAP benefit with equivalent TCA benefits. In the Social Service Administration, we have continued Family First implementation efforts to transform our child welfare system to focus on families and build a prevention-based approach that emphasizes partnering with children and families. Our transformation is focusing on enabling families to access evidence-based prevention services to keep them safely together, establishing qualified residential treatment programs to provide high-quality therapeutic intervention for youth who need short-term residential care, and implementing the new assessment process to determine the appropriate level for children and youth who are entering care. As of December 31st, 2021, we had more than 4,300 children out of home placements. The majority of the children, more than 3,000, are in family care settings. The other youth are placed in group homes, independent living, residential treatment, or other settings. In child support administration, the department collected and distributed $543 million in child support last fiscal year. Of that, $160 million was distributed to families previously receiving TCA, reducing the likelihood that families will become dependent on the state for financial stability. As of the first quarter of fiscal year 2022, $120 million was collected and distributed in child support. The amount collected per case has increased by 8% for $243, rising from $2,975 to $3,218, despite the number of child support cases decreasing by 8%. The intercept of video lottery winnings authorized by HB 907 has allowed the department to disburse $4.9 million in gaming intercepts to pay past due child support. The Step-Up program continues to be a success. As you know, this program provides eligible underemployed or unemployed non-custodial parents with assistance in obtaining employment that would enable them to achieve economic self-sufficiency and to meet their child support obligations. And on Everything, in 2018, the Everything Cloud platform was launched. In 2020, we implemented the child welfare module of the new Child, Juvenile, and Adult Management System, or CGMS, and the Adult Services module launched in 2021. And in November 2021, pretty recent, I'm pleased to report we completed the statewide deployment of our new Eligibility and Enrollment Application, or ENE. The ENE application supports programs such as SNAP, TCA, TDAP, long-term care, and other Medicaid eligibility programs, and is critical to the delivery of our economic assistance benefits. And deployments of CDM and E&E during the COVID-19 pandemic, while the DHS and MD Think staff was a major accomplishment and reflects the skill, innovation, and dedication of our MD Think team and our frontline staff. That concludes my opening remarks. Now, with your permission, I will move directly to the issues in the analysis.
Sure.
Thank you. In response to issue 1, regarding when the department would publish the monthly maltreatment data through December 2021, the department anticipates publishing the maltreatment data through December 2021 by the end of April 22. On issue number 2, regarding insights on the impact of the pandemic on child welfare caseload, the department is seeing a return to pre-pandemic levels of suspected child abuse and neglect cases. The trend in the number of cases directly correlates to schools' return to in-person learning. We will continue to monitor that current trend. On issue number 3, the department, to the extent possible, will work to address the proposed recommendation. On issue number 4, regarding the anticipated timeline for the relocation and additional benefits expected to be achieved with this relocation, we're on target to relocate in the fall/winter of calendar year 2023. The benefits to be achieved from relocating are structural and environmental health benefits, workplace safety and walkability benefits, workspace and technological benefits, and workspace efficiency. And I spell, the benefits in my written testimony. This concludes my testimony and response, and I will be happy to address any questions the committee may have. And if I may, I can then address Senator Young's question. Thank you for your patience. I want to say that it's a very good question. The benefits of relocating that I just conveyed are the ones that we believe are necessary and prompts our relocation. To your question about when you call, lines are not being answered, I'm being referred to other people. I want to be clear that what we're relocating is the HHS headquarters. So local Department of Social Services are the offices where the clients will walk in. So it's a different dynamic. What we have in this building, we intend to relocate, is the headquarters of DHS. I hope that your experience has not been with DHS, because you said the department, right? That the experience has not been with DHS. But if you do get a complaint that is directed to the Department of Human Services, please let us know, because I as a secretary, take those very seriously and will definitely address in the very time. Thank you.
Thank you, Madam Secretary. And Senator Young, I hope that response was acceptable to your question. And Madam Secretary, we appreciate your offer to work offline with any concerns that come directly related to DHS through your office.
Yeah, I really didn't have any complaints on HS. It's just been a general thing across the board with the state. And I want us to stay responsive. If I'm having frustrations getting through when I call an agency, I worry about the public. And I just want to make sure we're paying attention to that and make sure that there actually are people there that get back, either answer directly or get back quickly across the board, not just DHS. Thank you.
Thank you, Senator. Any other questions for the secretary or her team? Okay, well, Madam Secretary, I thank you for your patience. I know that you were here when I made my comments to your colleague, the Secretary of Health, about the committee's concerns about vacancies and personnel issues. As with the previous analysis, I know that we'll have a deeper dive on that during your overview, but certainly know that there are some changes either underway or that have already occurred in terms of DHS professional positions and qualification requirements, and how you propose to fill some of the vacancies at various levels in the department. So we'll look forward to continuing the conversation when we reconvene. We do have your document in response to the analyst. So I don't see any further questions from the committee. So with that, we will thank our analysts for their presentation, and thank you, Madam Secretary, and your team for being available to the subcommittee. And our paths will cross again in the weeks to come, and we look forward to continuing the conversation and serving the state together. With that, members, we have a meeting tomorrow at 10:30.
10:30 now, yes.
10:30.
Thank you, Philip. So we'll be together again tomorrow at 10:30, but to all of you, thank you and wishing you a great afternoon.
Thank you.
Yeah.